Hello, my name is Dr. Mark Socinski. I'm the Executive Medical Director of the Advent Health Cancer Institute in Orlando, Florida. Let's talk about the benefits of lung cancer screening. We do know from a couple of trials, very large trials, looking at populations that are at increased risk. These are generally patients over the age of 50 up to about 75 or 80, and patients who have had a prior history of smoking, at least 20, sometimes 30 pack years, that the use of screening CTs, low dose rapid CT scans. The bottom line is that it saves lives. We have data that's pretty consistent across trials done in the US as well as Europe that suggests that there's roughly about a 20%, if not greater, reduction in lung cancer mortality as a result of screening versus not screening or doing lesser things like chest x-rays versus low-dose CT scans. The other issue is that in the original study done by the NCI in the United States, there was also a reduction in all-cause mortality. Interestingly, these CT scans can pick up things like coronary artery calcification. So it can identify patients who may be at risk of heart disease. And by addressing the heart disease, you can potentially reduce mortality for that patient. So I think the primary benefit that patients at risk of lung cancer, and these are older patients who have a smoking history or a strong family history, is that it reduces your chance of dying of lung cancer. Now, what's the downside of screening? You know, as I say to my patients, the lungs are the organ that interfaces with the environment with every breath. And so we find a lot of things on CT scans that are not, quote unquote, normal, but are not necessarily cancer related. Granulomas, other scar nodules, the sequela of prior infections, the sequela of fibrosing diseases, and these sorts of things, which there are a number of radiologic criteria that we can put patients into either a low risk category or a high risk category. Obviously, being in a high risk category may prompt either an early follow-up or a biopsy, but being in a low risk category would put patients with a less quick follow-up and no need for a biopsy at that particular time. And so I think we can stratify patients based upon what their risk is, based upon the radiologic features of their cancer. So I think the field has done a good job of that risk stratification. And I think that with that risk stratification, we still see the reduction in mortality as a result of lung cancer. And I think that one of the things that we do know is that lung cancer screening is woefully under-practiced in the United States. There are many, many more patients who are at risk of lung cancer that are not getting screened, and therefore we need to make sure that patients are getting screened. And this is really a primary care issue. It's really not an issue for oncologists per se. It really is driven by the primary care team. It's also important for patients to know that the benefit in reduction in mortality that you see with lung cancer is very similar to what we see with mammography, with screening colonoscopy. And so if we're doing all these other things, we certainly should be screening for lung cancer because we will save lives as a result of the implementation of broad-based screening for our patients at risk of lung cancer.